Now we're switching over to talking about health, important component of the quality of life we enjoy in our community, ongoing changes and challenges, and we're going to be starting with Dr. Kate Perry. She is an internal medicine specialist, and then we'll be moving on to Susan Campbell, who is a nursing instructor at Washington State University. Welcome, Kate.
Thank you, Luann. I'm very excited to be here today to discuss with you the health of our community. Let me get my AV set here. I'd like to begin by letting you all know that in 2011 and 2012, the Benton Franklin Community Health Alliance, in conjunction with our area hospitals, the Health District, and a variety of community partners, including United Way, conducted a comprehensive health needs assessment for our community to identify what areas really percolate to the top in terms of issues for us. And what you can see here is the results of a question from a community survey that was part of that assessment, where individuals identified what they felt to be the most important issues facing the community. What you'll see is that the top 3 responses dealt with issues relating to access to health care, and the 4th most common response was obesity. For the next 15 minutes, I'm going to discuss the issue of obesity and healthy lifestyles, and then I'm going to turn the podium over to my colleague, Susan Campbell, who will discuss issues related to access to health care. Before I begin, I wanted to provide you with a definition. For the purposes of the data that I'll be sharing, I'll be discussing body mass index, or BMI. BMI is calculated using an individual's height and weight, and we define normal weight as a BMI of 18.5 to 24.9, overweight as a BMI of 25 to 29.9, and obesity a BMI of 30 or above. You may all have heard that we're experiencing an epidemic of obesity in the United States, and I wanted to share with you a series of slides from the CDC that I think make this point very powerfully. What you'll see in 1985 in looking at this map is that of states participating in the survey, none had an obesity prevalence of greater than 15%. Now I'm going to scroll through the years so you can see what has happened. So by 2010, there's no state in the Union that had an obesity prevalence of less than 20%. 36 states had a prevalence of greater than 25%, and that includes the state of Washington, and 9 states had a prevalence of greater than 30%. Currently, 2/3 of adults in the United States are either overweight or obese. We have some data looking at obesity and overweight rates in our community, and you can see that they pretty closely mirror the national statistics, with approximately 2/3 of adults in our area being either overweight or obese. The medical complications of obesity are very broad. I think most of us recognize that obesity is associated with a number of chronic conditions, including diabetes, an increased risk of stroke, heart attack. But if you look at this slide, which I really like, it demonstrates that obesity actually has an impact on virtually every system in the body. It's associated with an increased risk of sleep apnea, of lung disease, liver disease, and as a rheumatologist, I'm particularly sensitive to the impact on joints. And not only is obesity costly in terms of our sense of health and well-being, it's also economically very costly. In 2009, Finkelstein et al. Published a study looking at the obesity-related costs to our nation, and what they found was that obesity-related diseases account for nearly 10% of all medical expenditures in the United States, or an estimated $147 billion annually, and that was in 2009. You can imagine that that number is probably higher now than it was then. Now, all of you may have seen this headline in the Tri-City Herald last year when the Gallup Healthways Wellbeing Index ranked the Tri-Cities as the 9th most obese metropolitan area in the United States. The authors of that study went on to provide estimates of the cost, the economic cost of obesity in our metropolitan area, and what they estimated was that our cost was approximately $116 million per year for the total, for the care of obesity-related illness. They went on to estimate that if we were to reduce our obesity rate to 15%, we potentially could experience a savings of up to $64 million per year. Unfortunately, we do not have comprehensive BMI data for children in the Tri-Cities area. We have some data for Benton County, so I thought I would share the limited data that we do have, but please recognize that it may not be representative of the area as a whole. What you'll see is that 27% of children in Benton County, of 8th grade students, are either overweight or obese. And the obesity rates have actually risen quite a bit for children as well as for adults. Over the last 30 years, obesity rates have doubled in children and tripled in adolescents. We are seeing medical problems in adults, and in children now, that when I was in medical training, we never saw. We referred to pediatric obesity and adult onset obesity, and we've had to completely change the nomenclature and talk about type 1 and type 2 diabetes because we're seeing what used to be adult onset diabetes in children now. The type 2 diabetes actually can make up to 50% of new cases of pediatric diabetes now. We also see an increased rate of hypercholesterolemia, hypertension, and joint problems, bone problems, as well as psychological and social problems in children with obesity. So why are we experiencing this increase in obesity? There are a variety of complicated factors that include lifestyle factors, environmental factors, genetic factors, and social and cultural factors. But the bottom line is that we have experienced an imbalance in energy. We're consuming more calories than we expend, and over time, the consequence of that is weight gain. There are a variety of factors that have had an impact on this equation, both on the consumption side and on the expenditure side over the last few decades, and I'd like to share some of those with you. First of all, we eat far more processed food than we did 20 to 30 years ago, and we eat out more. And when we eat out, whether it's at a fast food restaurant or at a fine dining establishment, those meals tend to be higher in fat, sugar, calories, not to mention salt, than meals that we would prepare at home. In addition, unhealthy foods are ubiquitous. They are available everywhere, 24/7, and they're very aggressively advertised. And we've also experienced a phenomenon that some refer to as portion distortion, meaning that the standard serving size of a variety of foods has changed markedly over the last 20 years. Now, I'm not sure all of you are old enough to remember what a bagel used to look like 20 years ago, but it resembled in shape what we see today, but in terms of size, it's quite a bit larger. The same is true for a standard cheeseburger, a standard serving of French fries, and I'm sure you can think of a lot of other examples, the supersized candy bars, the soft drinks, etc. We have some information about the dietary habits of members of our community. We know that adults in our community, 75% do not consume the recommended 5 or more servings of fruits and vegetables daily. And returning to our 8th grade students in Benton County, you can see that the same is true. Now, turning our focus to the energy expenditure part of our balance. Over the last 20 to 30 years, we've become an increasingly sedentary society. We spend more time behind the wheel, behind the desk, and in front of screens than we ever have done before. And it's estimated that approximately 1/2 of adults in America do not get the recommended amount of weekly physical activity. And I wanted to share with you the results of this study that was conducted by the Kaiser Family Foundation and published in 2010, because I think the results really are very startling and shocking. What they found, they looked at media use among children ages 8 to 18, and what they found was that the average American child spent more than 7.5 hours per day using some form of media for entertainment. And these kids are such good media multitaskers that you'll see that they're actually cramming more than 10.5 hours of media time into those 7.5 hours. They also found that well over half of children in the United States had a television in their bedroom. Fully 50% had a gaming console of some sort in their bedroom, and a third had a computer with internet access in their bedrooms. The physical activity data that we have for adults in our community closely mirrors again the data that we have for the nation as a whole, with approximately 51% of our adults not getting the recommended amount of weekly physical activity. And again, we don't have complete data for all children in the Tri-Cities community, but again, looking at our 8th grade students in Benton County, you can see that 38% did not meet physical activity recommendations according to the Healthy Youth Survey for 2012. 52%, not surprisingly, had 3 or more hours of screen time daily, and 46% did not participate in physical education daily. So, opportunities for change. Addressing the obesity problem is going to require making the healthy choice an easy choice. It's going to require changing our environment in places where we live, where we work, where we learn, and where we play. And I'd like to discuss with you some promising strategies in all of those areas that may help to stem the tide and hopefully reverse this trend. First, in the community, we can increase access and affordability of health-promoting foods by supporting farmers markets, community-supported agricultural programs, pick-your-own programs and farm-to-institution programs. We can support community and home gardens. And many people don't recognize that breastfeeding is also a very important part in addressing the obesity problem. Infants who are breastfed actually have a significant degree of protection against developing childhood obesity. So policies in the community, in workplaces, in hospitals that support breastfeeding play an important role in addressing obesity. We can also increase opportunities for exercise in the community through community-wide campaigns encouraging people to begin to exercise regularly, through point-of-decision prompts in multi-story buildings encouraging people to take the stairs rather than the elevator, by enhancing access to places where people can participate in physical activity and making sure that community members know where those places are and when they're available. Promoting street and community-scale urban design policies, specifically mixed-use development, where residential communities are built in close proximity to the places people need to be on a daily basis so that they can use active transport to get to school, to work, to the store, to the post office, et cetera. And finally, we can enhance infrastructure that supports walkability and bikeability. Increasing the number of sidewalks and bike lanes and their connectivity is another important means at the community level of increasing our ability to get physical activity. In the schools, we can promote access to healthy food through improving the availability of healthier food and beverage choices in cafeterias. We can restrict the availability of less healthy food in vending machines, and actually there is federal legislation that will be going into effect for the next school year, restricting the sale of unhealthy foods during school hours in public schools. It's amazing that food is still used quite a bit as a reward in classrooms, and banning that practice may also be helpful. Farm-to-school programs, school gardening programs are also promising strategies, and limiting advertisement of less healthy foods in the school. We can also increase opportunities for physical activity in the schools by reserving or preserving recess time, by requiring physical education and making sure that physical activity takes up most of the PE class time, locating schools within easy walking distance and making sure that the routes to school are safe so children can ride their bikes safely to and from school or walk. There are also a variety of promising strategies in the workplace. We can promote the access to healthy foods in cafeterias, in vending machines, and at meetings and events. And business owners are finding a lot of creative ways to make it possible for their employees to increase their physical activity. Some are making their stairwells more attractive so people are more inclined to take the stairs. Some are partnering with local fitness centers for reduced membership fees for their employees. or actually providing on-site exercise facilities. Some are providing showering facilities and changing facilities, as well as bicycle racks to make it easier for people to bicycle to work. Some are making their employees aware of walking pet trails that are near the work site and promoting and sponsoring walking competitions. And some are allowing employees to use flex time to make it easier for them to work physical activity into their schedules. There are a variety of things that can also be done in the home that are important. We model behaviors for our children, and if we model good, healthy lifestyle behaviors, children are more likely to continue to do those as adults. First of all, we can make our homes healthy eating zones by restricting the amount of unhealthy food that comes in and teaching children to eat healthy snacks as a habit. We can get our families moving. As families, we can go on family hikes, family bike rides, and make those routine. Parents can also identify physical activities that children enjoy and try to make it so that they can participate in those activities on a regular basis. And finally, we can limit screen time. Try to keep, actually I wanted to point out to you just last week, based upon the study results that I just shared with you, the American Academy of Pediatrics has revised their screen time recommendations. They continue to recommend that children spend no more than 2 hours per day in front of a screen for entertainment. But in addition, they have recommended that infants up to age 2 have no exposure to television or internet access. They have recommended that televisions, as well as any internet-ready device, be kept out of children's bedrooms. And they've also recommended that meal times and after bed be no device times. I wanted to conclude by making you all aware of this document, the Community Health Improvement Plan for the people of Benton and Franklin counties. Again, it's going to require system-wide change if we're going to address the obesity problem that we have in the Tri-Cities. It's a much bigger problem than any individual or individual agency can address. There's a role for all of us, whether it's deciding to get more physical activity or to take the stairs, whether it's deciding to volunteer to help maintain a trail, whether it's deciding to look into starting a worksite wellness program at your place of business. So I'd like to thank you all for your attention, and I will now turn the podium over to my colleague, Susan Campbell.
That's great. So now we're all wondering what we're going to have for lunch. So let's talk a little bit about health access. There's a variety of ways that we could look at health access as a topic. And we could have looked at the minute details of who accesses health care at what particular place, at what particular time, who's going to the ER at 2 a.m. But I felt like that the best thing that we could do is look at 3 central themes. The emergency care, primary care, and technology and community care. So the first one is the emergency care for emergencies. This is a statewide campaign. And in the fall of 2011, the state sent a letter to all Medicaid recipients saying that they needed to refrain from using the emergency room for non-emergent care. At the same time, they notified the hospitals that there's this policy change in how they're going to be reimbursed for health care for Medicaid visits when it's non-emergent. And at one point, there was almost a 3 strikes clause going through the legislation saying, if you have been seen in the emergency room for non-emergent reasons, after the 3rd time, the hospital wasn't going to get paid. So that certainly produced a flurry of activity in our community as well as across the state as agencies looked at ways where we could change community behavior while not penalizing hospitals for providing that health care that they were legally and morally responsible to provide. So in our community, the health access team is the venue for monitoring the data in our citywide, both of our counties. So we did realize between 2011 and 2012 an 18% decrease in the ER use for non-emergent reasons. And we used 10 top diagnoses to evaluate this data. And in your show notes, in the little thumb drive that you got, you'll have a lot more data than we'll present here. One other way that we've been addressing the issue of emergency care is for emergencies is through the Alliance Consistent Care Program, which is led by Becky Groves. Becky and the emergency department staff, through their efforts, have realized a 61% reduction in the emergency room use for those that are enrolled in this Alliance Consistent Care program. So this program uses best practices, software systems, care mapping, just a really intensive case management program for those at greatest need. And what they're trying to do is to make sure that those needs are met before they show up at the emergency room door. Our second theme is on primary care, and I love this slide. I just think it's a great one for really emphasizing primary care. Data has shown that primary care is the best place for the best patient outcomes, especially for those who are having multiple chronic diseases, multiple chronic illnesses. So we're putting a lot of effort in our community on supporting primary care. So in order to give primary care, you've got to have primary care providers. So looking at Benton County, we see 1,317 people, that's population, per primary care provider, per one primary care provider. But look at Franklin County, at almost 3,000 people, population, per primary care provider, where Washington State's average is 1,222, and the national benchmark is 1,067, so just over 1,000. This data comes from the county health rankings, which is available online, and I've given you the link. And they're using 2011 and 12 data. We all know that we've been increasing the number of primary care providers available locally, but so has our population. So when we look at it as a ratio, it's pretty consistent. One of the things that we have been doing is filling the pipeline of primary care providers through education. The work that's been happening in our community with the DO students, supporting their training, the work with the family practice. I know Cadleck is building work with with the University of Washington for a family practice residency. And even at WSU, the whole community is supporting 11 students that are currently enrolled in the family nurse practitioner program. So we are filling our pipeline of primary care providers. The medically uninsured impact access to care because we see that those who are medically uninsured are often waiting the longest to receive care that they need for not participating in the preventative side. So again, in Benton County, you see 16% uninsured, but in Franklin County, almost 25% uninsured. And actually, in looking at Franklin County has the second highest percentage of uninsured in our state, where Yakima is the first. All right, so this is the cover of the 2009 summer The Economist magazine. And I actually keep this on a bulletin board in my office because I want to use it to help generate discussion with nursing students about the impact of health policy. Now, we could have spent lots of time talking about the Affordable Care Act and how it does or doesn't improve access to care. And I have provided just a ton of notes and lots of links of information that will help you if you need more information about the Affordable Care Act. But at this point, what I really wanted to leave with you is that how we pay for health care, the affordability, how we perceive being able to afford health care does impact access. And in our local community, our goal is to enroll 3,000 in the health benefits, through that health benefits exchange into the Affordable Care Act by the end of next year. But affordability of health care does impact access. Social determinants of health is simply a phrase that indicates that where you were born, where you grow up, where you live and work and play, all these things do impact your health. I love the picture of the city in the background with the gardening and a personal mission that everybody have their own little spot that they're growing some of their own food. But it is important where we join in the issues of health with the issues of the social determinants of health. There's a great publication now available on ebook through TED videos. TED now produces books, and it's called The Upstream Doctor. And Dr. Rishi Manchanda wrote this book, and he talks about the importance of simply having the physician ask, Where do you live? Tell me about it. And bringing in community health workers, which we have in our community, who can help ferret out what kind of things that are happening in a person's health that are simply related to the circumstances of where they're living. In the Health Access team, we are looking at expanding thought on where can we access primary care. And the pharmacies have been addressed as one of those innovative places that we may be able to expand not only immunizations, but other things like just the health education that we can spread throughout the community. So pharmacies are one area. The other thing that's occurring is the Faith Community Nursing Network, which has been recently become a part of the chaplaincy. Faith Community Nurses, an international organization, which we now have a local group in our community, are providing health care at the Union Gospel Mission, that the kind of health care and health and wellness services that nurses can provide, and we work right alongside nursing students to provide that. Taking a look at common messaging is important. This is a publication that's available through the state that we're spreading throughout our community. And this is our local version, which fits right inside of that says, we really want you to make a decision about where you're going to seek primary care services before you're even sick. And I have a whole box of these rat cards available for you all to take with you back to your organizations. And I have even more available if you run out. This is a publication, What to Do When Your Child Gets Sick. And we have identified this, the Health Access team has identified this publication, which has been researched by UCLA and shown to produce a 58% decrease in the inappropriate use of healthcare services when people are able to use this book side by side, either in a small group setting or in a one-on-one setting, to learn, how do I take a temperature for my child? What do I do when my child has an earache? The ER is not the place to go to, that there is a place to go with primary care, but what can be managed at home? So I couldn't pass up the opportunity to tell you just a hint of the excitement that I have in working with nursing students. Probably one of the best things about being an instructor is being able to work with great students who are taking the heart and the science of nursing, and they're looking at it through the lens of technology. Wow, how exciting. So you had to sit and listen to this part too. This is what kind of my era of technology, I don't know if you remember the tricorder in Star Trek, but I do believe that the incredible change is going to occur is in community health. That's if you want to say, the biggest bang for the buck. My first cell phone was a bag phone. I don't know what yours was. And computers had changed so much over the years. But what we're looking very quickly to, some say 80% of what the physicians are doing now, replaced in 10 years by technology. This handheld technology is making a difference. So we can say that people are accessing the web before they access their MD. The embedded health tracking, not just for blood sugars anymore. We'll have embedded health tracking for all kinds of things to keep us healthy. What used to be technology only available in the biggest of cities, then CT scans, PET scans, whatever you want to say, coming to every city. Then all kinds of imaging technology available to the provider's office. Now we're seeing, this is a hospital in your pocket. This is ultrasound. This is a little ultrasound machine, and I watched a video on it. And this is an ultrasound machine that you can just use at home. Whether it's checking on the status of your baby, or the video that's available that said that someone's checking on the status of their kidney transplant. And they're documenting this for their physician live from their home. The issue of using technology to improve healthcare access, right there. Biometrics. I'm looking forward to the biometrics that will allow us to check food for peanut allergies or water for water quality. We won't need a big department to check water quality if I simply want to check it, or if there's bacteria that's growing in whatever I've left in my fridge. What about the smart toilet? I'm not sure if I want this one, but the smart toilet may be the first to diagnose what's the result of what's creating all that diarrhea. I'm not sure, but you can look forward to this one if you would like to. The greatest impact may come from third world nations, who I believe will simply leapfrog over our current healthcare system and go right to this handheld, at your fingertips technology to impact primary care. The Kite is a really great little device. It's a little cardboard piece that fits on your clothing, that you wear on your clothing, and it makes you virtually unrecognizable to mosquitoes. So there was a little article in the paper today, if you had a chance to read it before you came, that talked about the rate of malaria going up, mainly from those who are traveling inside to the U.S. from other countries. But can you imagine the social impact of having a malaria-free Africa? This device was crowdsourced, and it will be put into testing in January of next year in Uganda, with an incredible impact it will make. So what seemed in a galaxy far, far away, really truly now is at our fingertips. And I hope that you sense just a little bit of the excitement of seeing what will happen as we access healthcare in a much different way in the future. Thank you very much. Thank you all.